Hello and welcome. On behalf of the Association of Professional Chaplains, I thank you for joining us today for our APC Professional Chaplaincy webinar, Caring for the Caregiver, Reducing the Stress of Vicarious Trauma. Today's presentation will include numerous videos. If you are connected via Wi-Fi, you may experience some delay while viewing these. To optimize your viewing experience, please close out of all other browsers and tabs, and if possible, use an Ethernet cable to connect to the Internet. A recording of today's presentation with the videos will be available if you are unable to watch them in real time. And I am pleased to introduce our presenters, Nancy Lynch, Dina Mitchell, and Sherry Racket. Nancy Lynch is the Director of Spiritual Care for Women's and Children's Services at University Hospital's Case Medical Center in Cleveland, Ohio. Her pediatric clinical assignments include critical care, ED, trauma, palliative care, hematology and oncology, and child and adolescent psychiatry. She recently initiated a pilot program at UH to integrate pet therapy with spiritual therapy, and she is actively involved with the Northeast Ohio Regional Pediatrics Ethics Consortium. She is an APC member and BCCI board-certified chaplain. She is ordained through the Presbyterian Church and serves as a parish associate at Church of the Covenant. Dina Mitchell is an assistant nurse manager, Angie Fowler Adolescent and Young Adult Cancer Institute, Outpatient Center, Rainbow Babies and Children's Hospital. Her 22 years of pediatric nursing experience includes care of newborns through young adults in the areas of post-surgical trauma, pediatric intensive care, ambulatory sedation for testing and procedures, and ambulatory hematology and oncology. Her administrative and leadership roles have focused on increasing the quality, safety, efficiency, and standardization of care for the pediatric, adolescent, and young adult patient within the ambulatory and inpatient continuum. Mitchell regularly presents continuing on care at the end of life of the pediatric patient with a concentrated focus on care of the professional caregiver in relation to pediatric health. Sherry Racket is a board-certified and registered art therapist and licensed professional clinical counselor in the state of Ohio. She worked as a certified medical technologist in hospital settings for over a decade before changing careers and has been practicing art therapy and counseling since the late 90s. Her experience includes individual, family, and group therapy and counseling with children through older adults in a variety of settings. Her specialization is in the areas of trauma and medical art therapy. She is currently the manager of the Family and Child Life Services team at UH Rainbow Babies and Children's Hospital in Cleveland, Ohio. Thank you for your attention, and I would now like to turn the call over to our first presenter, Ms. Nancy Lynch.
Thank you. Hi, I'm Nancy Lynch, and with me today, as Nick just said, are Dina and Sherry, and we are here today to talk with you about caring for the caregiver, with caregiver here being defined as any healthcare professional. This would include chaplains, of course, but also physicians, nurses, social workers, child life specialists, respiratory therapists, pharmacists, and anyone who works in a clinical setting. This presentation rose out of a combination of our own personal experiences in coping with death, trauma, and grief, and also the experiences of the staff with whom we work, some of whom you'll get to meet in videotaped interviews interspersed throughout our presentation. Our particular context is pediatrics and OBGYN, but the experiences we're about to share and the feelings they generate are pretty universal and applicable in any setting in which death, trauma, and grief are experienced. We'll be giving you an overview of the types of things that can contribute to compassion fatigue and burnout, and then provide you with some tools you can use to effectively cope with difficult situations when they arise. Our legal department has asked us to please note that as of September 9, 2016, University Hospital's Case Medical Center has a different name. Our new name is University Hospital's Cleveland Medical Center, although you will see the Case logo present in several of our videos. Our presentation objectives today will start with a discussion of trauma, death, and how we experience difficult situations at work. We'll then move to talking about our peer-to-peer psychological first aid program we developed to help staff support one another during difficult situations. We'll then close with strategies and tools designed to create an effective self-care plan. Here to talk more about our experience with trauma death, and difficult situations at work is Dina Mitchell.
Thank you, Nancy. Good afternoon, everyone. Hi, I'm Dina Mitchell, and I'd like to start our presentation. I'd like to start our presentation by inviting you to take a moment to think about a time when you struggled at work due to some kind of clinical situation. What happened? What made it difficult? And what was the hardest thing about this for you? If you're like us, chances are that many of your difficult situations had something to do with either a trauma, a death, or something that reminds you of a difficult situation that you've experienced in the past. Maybe you're reminded of a patient or a family you once cared for. Maybe you had a friend or a family member who experienced what was happening, or maybe you are remembering it being yourself at the center of this experience. These difficulties lead to the experience of sorrow. The concept and reality of experiencing deep and ongoing sorrow in healthcare includes and also extends well beyond death, dying, and human loss. By definition, sorrow is a deep distress, sadness, or regret, a resultant unhappy or unpleasant state. Sorrow may be experienced as affliction, anguish, grief, sorriness, woe, pain, and anxiety. The idea of storytelling or narrative is central to the work of chaplains. By inviting others to share their stories, chaplains help people to process events that have happened and to find meaning within those stories. Often we use these stories from various religious traditions to help make sense out of things that intrinsically make no sense. Our stories then are central to who we are and how we experience and understand life. Because stories are so important, we've invited staff and faculty throughout Rainbow Babies and Children's Hospital and McDonald Women's Hospital to share with us their stories. Our hope is that their stories will help you to frame your stories, as well as those of the patients, families, and staff with whom you work. The stories that unfolded through our interviews were prompted and were a reflection of the following questions. What is the reality of death and trauma? How do death, trauma, and grief impact us? What makes it so hard? How do we cope? How do we manage our stress? What do we need? How do we take care of ourselves? And how do we support those around us? Throughout our conversations and interviews, a common theme surfaced around the concept of continuum, which related to all aspects of our experience with death and trauma, ranging from grief and bereavement to wellness and self-care. Simply put, experiencing patient death, trauma, and secondary trauma is real, undefined, and ongoing. The sorrows that develop from these experiences are complicated and influenced by many different factors. And more importantly, we cannot afford to ignore the effect that it has on us. So let's start off by understanding more about the reality of death, trauma, and the resulting sorrows experienced across the spectrum of medical specialties and disciplines.
I love caring for children, but one of the downsides of this job is you have to deal with a lot of tragedies, and I can think of a lot of children. They always stay with you forever, and you always think about a life cut short. Basically, that's, there's always an aspect of children aren't supposed to die, babies aren't supposed to die, and that's something that sadly we deal with relatively frequently here.
By nature of my job, death is a frequent consideration in the pediatric intensive care unit. And although rare, it is something that we all struggle with as individuals and as physicians. Just so you have an idea when I mean rare, less than 1% of our patients die in intensive care units. So it's conceivable that someone might practice for weeks or months without encountering a death. But when we do, we take it very personally.
In Mac House, we tend to experience loss at an alarming rate. We have the thankfully extremely rare case of losing a mother. We have miscarriages and stillbirths and pre-viable babies born several times a week. We have the grief associated with the loss of a perfect child. The child that might never walk or talk or eat or breathe independently. The child that will never grow up and leave your home. The child that will require a lifetime of care.
When you start talking about patient loss and what it means, and I think the first thought is always a patient that I was there when they died and something big happened when they died and that sort of thing. And you know, I go back to something that is a very vivid memory. But as I thought about it more and more, I realized that the losses in my world and in the children that I take care of, I'm often, and the ones that are really truly more significant to me from an emotional standpoint weren't those sort of crazy deaths that happened during my residency, or you know, a child came in very sick, or you know, something happened quickly. It's more the patients that I've gotten to know because they were my patients from the time they were diagnosed to the time that they passed.
I think what's interesting about OBGYN is that people don't really think we have traumatic experiences, that it's really just these beautiful births. And very often we get to experience that and the privilege of that, but because of where we work and the patients that we've chosen to care for and the referral center that we are, we see a lot of things that I think many people don't realize you're going to see, and we see them in a high volume.
So there was a day that I did a D&C hysteroscopy, which was uncomplicated. I went home and I got a call in the morning from someone at another hospital that said my patient had been admitted and she had a uterine perforation and a bowel injury. And I mean, my first thought was just to hide. Like, I couldn't possibly go to work. I could not even think of how I could walk in the door another day.
And it took me a long time to recover from that. I ultimately had to go to counseling. I had to start an antidepressant, and it went on for months.
So what is the story of our sorrows and losses? Well, given the reality, we know that the exposure to trauma, death, and loss has the ability to produce the normal feelings of sorrow, sadness, deep distress, and suffering. And in turn, these experiences and feelings have the potential to profoundly affect and alter our state of being for undefined periods of time. With certain patient populations such as pediatrics, perinatology, and obstetrics, the impact of trauma and loss can be especially intense. As chaplains and healthcare professionals, some of the stand-apart distinctions related to experiencing difficulties related in particular to patient death and within the work environment include close relationships with patient and family, personally identifying with the pain of the patient and family, feelings of failure and the fear of failure in self-image, professional identity, and goals and expectations, uncertainties in regards to your own personal beliefs, challenges to assumptions about life and also personal mortality, losses in the past, both personal and professional, cumulative overall, and the anticipation of future losses. Trauma, death, and loss and the resulting sorrow on the professional level can be very personal and often conflicting. And sometimes these incidences are experienced above and beyond as an actual traumatic event. Listen closely for examples of these distinctions in the next video segment.
The most traumatic day that I've had at work actually was my first clinical day of working.
The mood in the room was unlike anything I have ever experienced.
It was very hostile, very accusatory. When the family came in, basically one of the family members said, "Who killed my baby?" I actually had to pick up a child that had passed away and put her in her mother's arms. And that was particularly traumatizing for me, and I still think about that now. Like just handing a mom her lifeless child was really hard for me.
I ran to the emergency room. The adrenaline's firing. This is what I've lived and trained for. I see this young boy and we proceed to try to revive him in the most aggressive ways as you would imagine. We open his chest, we squeeze his heart. We could not squeeze life back into him.
I can't experience everything that should rightfully be experienced because I just feel like I can't stay in control and I can't do what I need to do to take care of this family and this child. So usually it's just going through the motions, and not going through the motions, but doing what I need to do.
And he looked just like my son. He was 1 year older. And I had to go tell his mother that she had lost her son. She ran around the room, she hit me in a way of frustration, like this cannot be true.
And you feel physically ill, but then somehow you feel guilty about it because you're watching other people's pain and it's not your child. So somehow it feels wrong that it feels like it's your pain.
It just felt like hopeless, almost like I don't even know what to do. I don't know what to say. I don't know where to go to find someone for this child. I don't know what to say to all of the rest of our staff who have been working tirelessly to try to save this child's life, to try to save countless other children's life in the moment. And it just felt wrong.
It felt like that you were standing under a funnel of crap, is what it felt like.
I could not squeeze life back into his heart, nor could I adequately cradle his mother's heart in that situation.
Okay, so just to capture a few of the comments that you may have heard and picked up through those stories, how does it feel to experience a traumatic event? We heard people share that it was like standing under a funnel of crap, that it was overwhelming, difficult, heartbreaking, hopeless, uncertain, tense, immobilized and frozen, lots going on, lots to do and manage. Sometimes we don't feel at all in the moment. We defer feelings until later when we have time to process the emotions associated with our grief, sadness, anger, shock, disbelief, and confusion. As if these events are not difficult enough, there are several things that we have identified that have the potential to increase our distress and grief and also make it more difficult to process and work through. The following stories will highlight some of these contributing factors.
I think what's challenging for ER is that there's no time to debrief, there's no time to regroup, there's no time to pause, because as soon as you're done dealing with one crisis, there's still an ER full of patients that are waiting to be seen, there's still residents who need to present patients, there's still results to discuss, and so there's no time to close the very traumatic case before you have to just get back into working.
And the other part that's hard is that I really only allow myself the 45 minutes that it takes for me to drive from the hospital to home to process that grief, because then you have to get home and be a mother and a wife and a daughter and a sister to people that don't need to know all of the terrible things that are out there in the world.
You keep it in, and then most people don't understand it. Like if they don't work where you work,
or in the environment you work in, they think, okay, you, like I always say, it's not a factory where you build your pieces and then when the whistle blows, you go. Because you're thinking about them, whether they're, like when they're doing great things, you think about them at home. And when they're doing not so well, you think about them at home.
And you feel like you're entering into a war zone. And then you step out of it back into the real world of your home and your family. And that has to be your new reality. And I have to somehow split my personality so that I can be Catherine that deals with the children in the war zone and then mom, and not let those two things cross over, because that's not fair to my children.
So when we look at these contributing factors and listen to the stories that were just shared, really you can group them into three different subsections. One being how we process, opportunities to process. The second being balance, work-life balance. And the third being boundaries, professional boundaries, and boundaries between work and home, the margins, so to speak, that are unstated. One of the important things to note about the majority of these factors on this list is that we, both individually and as a team, have the potential to impact and proactively change our experience in navigating through difficult and traumatic situations before, during, and after. And we will talk more about how to do this later on in our presentation. Significant events, especially involving children, have been identified as potentially traumatizing events for the healthcare worker and fall within the list of the terrible 10 critical incidences. Exposure to critical incidences, such as the death of a baby or a child, have the ability to produce an immediate or delayed stress reaction that can be profound and altering. Remember, this type of stress, or rather distress, is a normal response to an abnormal event, and you can see that underlined on your slide. You will hear this stated more than once today. Now let's take a moment to listen to Marty share his story about a particular critical incident that he experienced earlier on in his career.
I had a delivery, and it was a complication of the delivery called a shoulder dystocia, and the baby's shoulder was stuck, and it was really difficult to affect the delivery. And I was there. There was a bedside nurse, there was myself, there was a senior and junior resident with me, and the baby was stuck for a long time, and I kept working and working to try to get it to come out, and at times I had my doubts as to whether the baby would come out and live or not, because it probably, I remember them counting down, it took 5 or 6 minutes to get the baby out, and the baby was stuck for that long. I was finally able to deliver the baby. The baby came out, the baby lived, ultimately okay. Did have a problem with the shoulder that was stuck. And it took me a long time to recover from that. I ultimately had to go to counseling. I had to start an antidepressant, and it went on for months. Before this all happened, it really, it affected me such that, at the time all 3 of our kids were at home. They were still in grade school and high school, but they couldn't understand why I was being so mean. And, after several months, my wife, who's also an obstetrician, said, "Marty, you have to go. This is just not right, what's going on." So I did go talk to a counselor and talk to my primary care doctor, and he started me on an antidepressant. And then gradually, over the next few months, I began to feel better.
Okay, so the reality of being in healthcare today, here in this room, here attending this webinar, is that these abnormal events that you just heard about become a part of our normal everyday life. And as we've just seen in Marty's story, when we do experience these stress reactions, we can find ourselves questioning or denying our feelings, so that sometimes we are left as the ones feeling abnormal, quote unquote. Traumatic events that don't necessarily result in death can have a long-lasting negative impact requiring assistance. The critical incident stress continuum, just to read through this quickly, the nature and reality of caring for acute and chronically ill patients, especially children, gives way to the increased likelihood of experiencing critical incidences on a constant continuum subject to associated cumulative effects. Speaking of cumulative, but it will catch up to us if we're not careful, and even sometimes when we are, consequences of cumulative stress. The cumulative effects of this type of stress, of a critical incident in particular, can lead to compassion fatigue or even vicarious trauma, which is defined as the trauma we experience from witnessing the trauma of others. Some of the factors that can contribute to chronic stress include feeling overwhelmed, the volume and magnitude of our losses, non-accidental trauma, not having time to process our losses, not knowing how to process our losses, and the denial of the effects of grief. If we do not actively seek ways to prevent and combat the buildup of these stressors, the effects can be detrimental and life-altering. And here to share with you more about vicarious and secondary trauma, and furthermore, a unique way that we can address workplace stress in a proactive and positive manner, is Nancy Lynch.
Thank you, Dina. Vicarious trauma is a term that was coined in the late 1990s to describe a type of compassion fatigue specifically related to trauma. I had been hearing when I first started working as a pediatric hospital chaplain, over and over again from staff, that one of the most difficult things that they dealt with is these horrible, awful things happening during their shift, and then having to just pick up and carry on as if nothing had happened. And I had heard this over and over again, but didn't truly appreciate it until the day I was called in to do what I thought was a fairly routine blessing on our NICU, our neonatal intensive care unit. So while I was in there doing this blessing, this baby who was very critically ill began to bleed out. And in the process, so everyone is, of course, in high stress, and the family is just devastated. One of the grandparents starts to have a heart attack. We have to call an adult code on the grandparents. So there's lots of moving parts going on. And, after this happened and the baby died, everyone's crying. The surgeon's crying, respiratory's crying, the NICU fellow's crying, the nurses are crying. The family, of course, is just in shock, and half of them are over in the other ICU for the family member. And, I got finished as a chaplain handling all of this as best I could and providing support, and I got back to my office and I was like, what just happened here? How did we go from being, this routine blessing to this? So I wandered on down to our emergency department, and I was talking with my friend Elizabeth Gonzalez, who's the social worker down there, and I said, "You're not going to believe what happened." She said, "Yeah, I know. We've had a lot of those this month, too, because our PZD, we're a level 1 trauma center, we had that particular month 9 pediatric gunshot wounds come in, and she said, staff is just really struggling with this." And so we kind of were talking and said, really what we need is some sort of way for staff to help staff, because a critical incident stress debriefing, trying to get the entire team together days after this happens just does not work. So we need something that we can do right in the moment that's really fast, that will enable us to be able to process a little bit about some of these awful things that happen, and then enable us to continue on with our day. And that's what I'm going to present in this next section for you. So the effects of vicarious trauma, very, very similar to post-traumatic stress disorder. It's as if the trauma has happened to you, because in a sense it did. You experience vicarious trauma when you feel traumatized by your experience. And it doesn't have to be a really horrible experience. It's just what's hitting you that day. You may be great for the first 5 traumas that come in, and then the 6th one comes in and you're like, okay, I'm done. Or you might be great with 10 normal, I don't know if there is such a thing as a normal trauma, but one that reminds you of something that happened to you, or something that happened is, something that reminds you of something that happened to a loved one. That can be enough to put you over the edge. So it's really very, very context specific and very personal about how you choose to define trauma. Statistics about the effects of vicarious trauma. The typical rates of PTSD in healthcare workers range from 6 to 50%, the estimates, and it's also estimated that 60 to 90% of those of us who are exposed to trauma report varying levels of cognitive, emotional, social, or psychological distress. So on these next couple of slides, I'm just going to present some laundry lists of potential responses that you may have in response to trauma. So I'm going to just give you a couple of moments per slide to just read down these. And what I'd like for you to do, just for yourself, is kind of tick off on your fingers, how many of these you yourself have experienced after experiencing something that you yourself would define as traumatic. So when I present this to groups of healthcare providers, oftentimes what I'll say is, okay, how many in this room have raised, experienced at least one? Everybody raises their hand. How many? 5? Many people raise their hand. How about 10? How about 15? And you kind of keep going up there. And my response to any of these is congratulations. If you have experienced any of these responses to trauma, you are a normal, empathetic, caring human being. You should be having nasty responses to trauma, because this stuff is not normal. Most people don't experience the kinds of things that we experience. Typical emotional responses to trauma, same thing. Just take a moment and kind of swing, look down this list. Shock, sadness, feeling overwhelmed, emotional swings. How many of you have experienced at least one of these? How about 5? How about 10? That's good. We tell our providers here at the hospital all the time, that's great. We want you to feel these things. We just don't want them to stay with you. We want you to feel them and then process them. So behavioral responses to trauma. I think this particular category is especially applicable to chaplains and maybe also providers that work in acute care settings, because you really don't have time to process in the moment what's going on. You have to respond. You have to be able to rise to whatever occasion you're being asked to rise to. And so we tend to sort of stuff these things. And So you have to be really good at identifying your own individual behavioral responses to trauma. You know, are you withdrawing from your friends and families? Are you finding yourself experiencing conflicts, you know, more conflicts at home or at work? Substance abuse, self-medication. I know for myself, I realized once that I had really not been handling all of the traumas that I had been exposed to the night that I ordered a pizza. And so I ordered this pizza. I was looking forward to it. I didn't feel like cooking, and pizza arrives, and it's the wrong pizza. And so I'm talking to the pizza delivery guy, thinking that I'm coming across as a normal, rational human being, right? And I'm like, you know, I can't eat this. It's got black olives on it. You know, I can't eat this. Well, you can have it for free. Well, I don't want it for free. I want what I ordered. And I'm thinking all this while to myself, yes, I'm very rational. I'm coming across, but I'm watching the pizza delivery guy kind of back away from me. And I'm like, okay, yeah, clearly I'm not coming across as rationally as I think, and it's time to take a step back and be a little bit more intentional about processing some of the things that I have not been processing. So again, you know, figure out what your own personal behavioral spectrum is, and pay attention to it when you see yourself sliding into those sorts of things. Typical physical responses to trauma. A lot of times with healthcare providers, they have never made that connection with physical things that they've been experiencing and some of the stuff that's happened with them. So fatigue, difficulty sleeping, headache, backache, GI symptoms, all of those things on the list. You know, your issues are in your tissues, as they say, and there's a lot of truth to that. So making sure that you are aware of this is important. All of these responses, again, we want to just stress, are normal. They are normal responses to really, really abnormal situations. So our conclusion here is that our work is difficult, and peer support, our peer support for ourselves, is essential in coping effectively with our daily challenges. So psychological first aid is what we are practicing here in our setting. What is psychological first aid? A definition that I found is compassionate and supportive presence designed to mitigate acute distress and assess the need for continued support. Effectiveness has shown that, you know, the social support is the most powerful protection for us against being overwhelmed by stress and trauma. And what is social support? Social support is being truly heard and seen by the people around us, feeling that we are held in someone else's mind and heart. So, you know, you could tell the mailman, for example, about your bad day. The mailman might have empathy for you, but the mailman doesn't get it. The mailman does not really understand what it means to see things that you cannot unsee. And so talking to one another really helps, as you'll see in this next video clip.
It was just very scary thinking you go from 1 minute, everything's fine, we're going to have a happy, healthy baby, to feeling like you're in a little bit of a scary, hopeless situation, and sort of trying to go through in your mind all the things you should be doing, and also not trying to let the fear and the anxiety sort of take over. Try to remember the steps, things you can do to intervene.
And then afterwards, as we're talking about what we could have done better from a medical, emotional standpoint, we talk about how did that go for you? You know, I asked them, a lot of them are young, impressionable. They didn't go into OB/GYN necessarily for these moments, or they didn't realize how it would feel to be the care provider as opposed to the medical student or a family member or friend if you had somebody who went through it. And then we just talk it through.
I think just realizing that others were feeling the same emotions I was feeling. I could see it in the eyes of the other resident, but just to have someone else verbalize, wow, that was really scary. I was really worried. I didn't know what we were going to do, and realize that you weren't the only person who felt that way. And it also helped to have my attending or my boss sort of reiterate that he also felt like worried and, you know, felt a little anxious about the whole situation.
There are also times where we just sit together as a staff and just talk about these instances. You know, it's not always death that's emotionally taxing as a nurse. There are other situations that have been very traumatic or violent, and sometimes you just need to bounce ideas off of one another. Also, just to comfort them and let them have open-ended conversations has been very helpful as well.
You just have to say it out loud, and I probably didn't say it out loud enough, and I walked around with a lot of internal chaos. Shared it with my friends, maybe shared it with one attending, shared it with a nurse, and then over time I realized most everybody else around me is feeling similarly, and somebody just has to have the voice to say something.
So the value of psychological first aid is finding someone with whom you feel safe, because finding someone that you can safely talk to about some of the things that you experience is one of the most important things you can do to promote positive mental health. Who needs psychological first aid? Everyone. We all do. Depending on the day, the situation, the context, and whatever else is going on in our lives, we all need psychological first aid from time to time. And again, peer support is essential.
I think oftentimes, though, we don't have that time to kind of debrief and kind of break things down. It is helpful, kind of whoever was leading the trauma or leading the resuscitation for a difficult case, that they take a minute afterwards to say, okay, everybody kind of come together and let's talk about what happened.
There are also times where we just sit together as a staff and just talk about these instances. You know, it's not always death that's emotionally taxing as a nurse. There are other situations that have been very traumatic or violent, and sometimes you just need to bounce ideas off of one another. Also, just to comfort them and let them have open-ended conversations has been very helpful as well.
It helps because you feel that you're not, you're not alone. It just helps to just sort of say, wow, what's going on in the unit, and if I get upset, I get upset. So
I think only staff could help staff in a situation like that. Only my colleagues and my peers can truly understand what that feels like.
Sometimes it can be hard to have superficial conversations because what you really want to talk about is the awful things that you saw. And so to have a group of colleagues and friends that you work with that you can really talk about the meat of what you experienced, the life and death stuff, is very helpful, because that's what you think about all day,
If you take that minute and kind of talk to the whole team and kind of say, hey, look, this is what happened, these were the injuries that this person sustained, and kind of just do a little debrief and let people kind of express maybe some thoughts or concerns that they had, and I think it helps the rest of the team, the nurses, the remainder child life staff kind of go back and deal with the next situation that we have to encounter.
So the purpose of psychological first aid is to help us to cope effectively with our daily challenges by offering on-the-spot compassion and support to one another. Our Caring for the Caregiver protocol uses a very, very simple acronym, ABC, and it stands for Ask, Be There, Care. ABC is similar to critical incident stress debriefing in that provides acute care, but it differs from CISD in that it happens right away and anyone can do it. So for example, I'm on the critical incident stress debriefing team at my hospital, but a critical incident stress debriefing occurs by definition sometime after the fact. So it's 24 to 48 hours after the dust has settled, so to speak. What psychological first aid is designed to do is to provide us with something that staff can do, and it's something that anybody can do. A unit clerk can initiate ABC, and it's a simple enough protocol that everybody can remember it. So our objectives of ABC are to process and debrief what's just happened, to stop the emotional bleeding by providing on-the-spot or post-shift, maybe if you can't do it right then, post-shift care for colleagues, and to reduce the risk of developing vicarious trauma and or psychological PTSD. ABC is not counseling, it's not a treatment for PTSD, it's not a cure for trauma, vicarious trauma or PTSD, and it's not a substitute for therapy. What it is, instead, is simply the earliest point on a continuum of additional care options. It's caring by caregivers for caregivers. The way that you provide ABC is very simple. You call an ABC huddle, and anyone can call an ABC huddle. And in the huddle, you gather everyone around and you ask, are you okay? Ask everyone how everyone feels about what's just happened. And note, this is a time to share feelings, not to evaluate performance or to do a little mini M&M. The focus here is on staff support. And give everyone who wants to talk a chance to share, but please also note that sharing is not required. When I've presented this in groups, I invariably will get introverts raising their hand saying, Nancy, this is my worst nightmare to have to share my deepest and most personal feelings with people in a group when I don't even know what I'm feeling just yet. And I'm like, you don't have to. This is not a requirement. We're not going to force you to share. It's just an opportunity for you to hear and to have validated that, yeah, what just happened was really difficult. And then you be there. B is be there. You're going to validate one another's thoughts and feelings, remembering that whatever someone is feeling is normal and that it's all a normal response to a really abnormal situation. So you don't judge other people's reactions. You recognize that not everyone processes things the same way, and that's okay, and you keep it confidential. I tell people sometimes the two worst words that you can use when you're providing ABC or really any kind of active listening is at least. You can pretty much know that anytime you're introducing an at least clause to the conversation, you've stopped the open, honest, and transparent sharing of feelings because you've just told somebody that what they're feeling is not valid, that they should not be feeling that way. So what you want to do, of course, as chaplains, we know this, is to validate, normalize and validate whatever feelings are being expressed. And then finally, you care. You offer some sort of care. Assess what the colleagues need, what your colleagues need, and remember these needs are going to be different for everyone. On the NICU, for example, our nurses will sometimes say, you know, I really would just sort of like to have time to, you know, go to the bathroom, or maybe you get a cup of coffee, or in the ED, you know, I just need to get outside and get some fresh air. You know, whatever you need to do to remind yourself that there's life outside the hospital is care, and again, it's very individual. So you meet those needs if possible by offering care and compassion. You listen, you validate the feelings, offer additional resources if you feel that they're needed. Employee assistance programs, critical incident stress debriefing if a more formal response, widespread response is indicated, counseling, therapy, spiritual care. We've introduced a program called Tea for the Soul here at my hospital that Spiritual Care has introduced, and we have this little mobile unit with a cart, and we put tea and sometimes cookies or chocolates on it. We put aromatherapy oils on it. I have a pet therapy dog that comes to work with me every day, so we'll take the golden retriever and the Tea for the Soul cart down to whichever unit is experiencing a difficult time, and that's been really well received, not so much because, you know, anything that we're offering is all that earth-shattering. It's more just the acknowledgement and the validation that, yeah, this was really hard and somebody cares. So the caring is really an important part of this. Ideally, again, ABC should be done before the end of the shift, before everyone goes home. And we try to tell nurses in particular, or even the residents, during shift change or sign out, if you can just take a few minutes to share what's happened on your shift and be able to offer that care and compassion to one another, it can make a big difference in how someone ultimately processes whatever has just happened. So, how ABC helps.
I think it's very important that you're doing this, that we're embarking on this adventure and this project.
And debriefing is important. It's hard to capture everybody. The day after, whoever was taking care of the child that night before is gone home and is hopefully sleeping. But debriefing definitely helps to get everybody in the room and talk about it some more.
When you shine the light on someone else's path, you can't help but shine the light on your own. And so I think if we ask, if we be there and we care, it's not only for others, it's also for ourselves. It's a reciprocal process.
So self-care is essential before the traumatic situations happen to help you develop and strengthen your coping skills, and then after the traumatic situations to help you heal. Here to talk with you a little bit about self-care is Sherry.
Good afternoon, everyone. So I'm going to shift gears a little bit here, and I'm going to ask everyone with the next slide to really kind of focus on this image as I read an excerpt from one of my absolute favorite authors who happens to also have a PsyD and works and specializes in self-care and works specifically doing therapy and providing support to helping professionals in a variety of different fields, whether it be psychiatry, psychology, counseling, those of us who work in a medical setting, nurses, physicians, therapists of various disciplines. So I'd like to share an excerpt from one of his books. His name is Robert Wicks, and one of his books is called Riding the Dragon. So he's written quite a bit academically around vicarious trauma and compassion fatigue and developing self-care protocols and plans. But he's also written a couple of very easy read books, this being one of them, that can be uplifting, inspiring, and very validating to read. So this excerpt is from that book. He's also, much of what I'm going to talk about throughout the next portion of the presentation a lot of it has been adapted from his work, particularly from the book Bounce. Living the Resilient Life is another one of my favorites by him. So focus on the image and listen to my words. Camels are fascinating animals. They can walk through the desert carrying their cargo for days without water. They're able to carry very heavy burdens. Yet even these wonderfully sturdy animals will dry up, fall down, and die if they are unable to find water and rest at some point. Even the strongest among us must stop for renewal in the oases that dot the parched deserts of life. Like sturdy camels, healing professionals are able to journey with others in the most difficult circumstances, helping them shoulder their burdens through psychological and spiritual deserts without frequent nourishment for themselves. So how do we do that? Obviously, there isn't one simple response available to keep compassionate persons afloat in difficult times. However, a primary and effective response is to be aware of our own safe zones and oases. Then we need to visit them on a regular basis in order to avoid drowning in the stress that comes our way. So where do we start and what do we do about that? How do we develop and practice a self-care plan to visit those oases and to be focused more on what we need to do for ourselves to take care of ourselves? So first of all, we do need to ask ourselves, why is self-care important? And because we need to recognize the importance of self-care in our work. We need to assess where we are presently with our self-care. So we do have, we have provided tools for you to use after today's webinar that you can use for a self-assessment. There's a self-assessment document that is part of this presentation, and you can assess yourself on your own time and see where you fall on a continuum by simply scoring it. And then there's also a handout on beginning steps to developing a self-care plan. So that is also an attachment that was sent along to you. So it'll help you either begin to develop a plan or maybe change an existing plan that you may already have. So this is all easier said than done, as we know, particularly making a commitment to self-care and being consistent with your plan. So it's important to make time for it, even when we don't feel that we need it. That's probably the most important time to remain committed and be as consistent as we possibly can be with whatever our plan is. Because in essence, this is the preventive practice that really helps us address compassion fatigue before it leads to burnout. It helps address compassion fatigue before it leads to vicarious trauma, and much of what Nancy shared in the earlier part of the presentation. So also recognize, too, that self-care plans can ebb and flow. They can change over time. They can evolve over time. You know, there may be times in our life when it's going really well and we're doing really well at it, and other times when we're not. And that's perfectly normal for that process to ebb and flow. So something that, you know, worked with you at one time in your life might not work anymore, and you'll have to change your plan to adjust to that. There may be moments or periods when we lose balance or focus, and we have to reassess and readjust, and that's all to be expected. So as all of us probably know, at least I abide by this often, is the one thing that we can always count on is change, because it continues to happen. So definitely expect your plan to change, and remember that life is a process, and so along the way, be kind and gentle to yourself in embracing self-care as a process as well. So one of the things I'm going to talk about that's, of course, important in developing a self-care plan is laughter. So here's some humor to think about, which, of course, you know, we've been infusing, and this infuses even more into thinking about your own self-care plan. So we're encouraging people to become involved in their own rescue. It's kind of a funny video, but self-care plans are important, and rescuing ourselves is important when we think about helping others and the need to do that before we can give of ourselves to others. So what are the domains of self-care? There's a lot of research on this, and there are different domains and different types of research. So what I've done for the purposes of this presentation is to put them into 5 categories, or 5 domains. So there's, of course, the physical domain. So all of the things that, some of the things that you'll be hearing in video clips to come. But the physical side of self-care is sleeping and eating and exercising and attending to your own health care. You know, seeing the doctor and being mindful and consistent with your visits and regular checkups and things like that. When we lose sight of those things, the physical aspects of even the vicarious trauma and the symptoms that Nancy talked about can sometimes catch up to us. There's the emotional and psychological domain of self-care. So, you know, what are you doing for yourself emotionally and psychologically? Sometimes hobbies definitely support that. Reading, vacations, journaling. I like to make it a point here to say, you know, engaging in your own therapy with a therapist or a counselor is extremely important. And oftentimes I've heard people feel that, you know, if I have to talk to a counselor, you know, there's something wrong. I'm weak. I'm not strong enough to do this work. But I think truly it's just the opposite. If you're seeking the therapy and you're working through what comes up for you and doing this difficult work, you're doing exactly what Nancy mentioned earlier, because all the issues are in our tissues and they can have an impact, and if we're not taking care of ourselves, not just physically but emotionally, that can lead to more difficult struggles. So I think addressing that on the same level that we address the physical and all the other aspects is really important. The spiritual, or what I like to call feeding the soul, reflection, meditation, finding meaning and purpose in your life. The spiritual aspects can also be part of that therapy. Maybe it's a spiritual counselor that you work with versus a traditional talk therapist, or an art therapist, or any type of therapist who provides mental health support. And then there's the domain of relationships. So are you spending time with your partners? Are you spending time with family, with friends, with pets if you have them? In general, connecting with others in your life. And then there's the workplace domain, which Nancy focused on hugely in talking about psychological first aid and the ABC approach here at our hospital. But are you taking breaks and lunch for yourself? Are you seeking peer support? Are you engaged in some type of mentoring or mentorship with another person, or a colleague or a peer? Are you engaging with a supervisor? Are you maintaining healthy boundaries in your workplace? So in the video that follows here, you'll hear a lot about what I've just talked about in the last couple of slides. So as you're watching, please pay attention. Some of them might be specific and particular patient stories, but as you watch, think of all those things and those 5 domains of self-care and what people bring up in these videos as examples with their own self-care plans.
I would say, and I talk to a lot of people now, is, what kind of hobbies do you have? If you do not have them, you need to find one. It is very important to be able to escape from work. I mean, nursing is as rewarding as it is a very difficult job to be in. It is a very difficult career path because the seriousness of it. You are dealing with life and death. You're dealing with long hours. You have to be able to relieve yourself and be able to re-energize yourself and come back the next day if you're working 3 days in a row. So you have to know what it is that can make Stacy feel better at the end of the day.
Well, I usually exercise, I guess. That's probably like my go-to, because it's sort of hard to leave things stuck inside. I think when you go out, usually outside, like go outside and exercise, it just kind of gives you a release somehow emotionally or intellectually or something.
I think it's always important to practice self-care. I mean, if you're religious, I go to church, so I often pray or kind of use church as a time to sort of think through things. I think making sure you take care of yourself, get enough sleep, get rest. Exercise is a great outlet for me. Those are all things I try to keep up on.
This next video clip, or I should reiterate, some of what you might have heard more about or should have heard more about in that last video was the importance of hobbies and exercise and religion and the spiritual side of self-care and prayer and going to church. In this next video, you'll hear a few more different examples.
It looks like we're having some difficulties with this file, so I'm going to have to include it in on the recording after the session is completed.
Okay, I'll continue on.
Sorry about that.
That's okay. In this particular video, there's just, more folks talking about different ways that they practice self-care. So one person mentioned shopping, and a key thing to the video that we missed here is the difficulty in finding the time to devote to self-care, which is a challenge for all of us. And if we're not challenged by that, then there really is something wrong with us. All of us lead such busy lives that I think one of the biggest challenges with developing a self-care program is really finding the time and dedicating the time and staying consistent and practicing it.
Excellent. And like I said, I'll include an additional link for that in the recording.
Okay. I feel like we missed the slide. Yeah. Whoops. Hang on a second here. I think I lost my place a little bit. Okay, here we go. There we go. Okay. So how might self-care look different in response to loss and grief? So really, the points that are listed here on this slide are, while they are, of course, applicable to self-care in general, they can be particularly important when we think about self-care in response to loss and grief. I think it's important to remember that it's a personalized practice. So it looks different for every individual, and what works for one person might not work for another. Coping with loss and grief is certainly unique. It's definitely unique in those who are in the healthcare setting because we can see it more frequently. And then I think it's also important to have an openness without judgment, and really that really allows us the opportunity to learn from each other and also learn about each other and in order to better support one another. So in the next video clip that you're going to see, part of experiencing loss and grief and death in our setting, we're in a position where we have the unique opportunity to build relationships with patients and families, of course, during some of the most difficult times in their lives. And so when there is loss, we have the honor and the privilege often to attend funerals if we choose to do that. And a lot of times that becomes a real question for folks. Do we attend funerals? Do we not attend funerals? What is the boundary there? And sometimes that particular boundary can look different for different people because what works for one doesn't work for another. So we wanted to share this video because it does have some perspectives that we can share from folks who are here in our system about the importance of funerals and what it means to them to attend, but there's no right or wrong. I mean, it's definitely an individual and personalized practice.
I think rituals like funerals help us to tap into that and to remind us that this is not all there is. And I think they also bring us together as a community, and I think that community is essential when you're trying to cope with loss.
Hard as it was for that, and as difficult as it was for us, we relied on each other to help ourselves through it. Going to the funeral was very, very important to me and to all of us. It was kind of like our way of finally the official goodbye.
I usually try very hard to attend the funeral if I can. I feel when I walk out of the hospital immediately, I try to acknowledge my feelings and not, I think it's very important to acknowledge what has happened as opposed to, denial, which is a very easy thing to do, sort of, push it aside and move on with your day. I think I always try and think about what happened and pray. I think for me, there's some comfort in that.
So I'm going to shift gears a little bit here. Since you've been hearing a lot throughout this presentation about how we can support one another, keep that in mind as you look at the cartoon on this slide. In the spirit of infusing humor, of course, these two mice are not doing such a good job at being perceptive, available, or listening to one another, as we've been talking about throughout the presentation. So on to some things to consider when you're creating your own personal self-care plan. And as I mentioned, the document attached to this to help you do that is just a template to use to get started. But laughter is certainly important, and given that we just shared the cartoon, that's the first bullet point on the slide. Second is knowing your own values, recognizing the difference between what you can control and what you can't control. As you're planning self-care, planning for self-care, there are some things that we just don't have control over, and there are times when we have to really accept the fact that we have to let those go and find a way to come to terms with that. Engage in self-appreciation. Celebrate the small accomplishments. They're more important than we all know. And practice gratitude. And I have a book reference here because for myself, there have been times, and I have found practicing gratitude in this way extremely helpful during the times when I'm in a valley rather than a peak in my life and in my work. But to really mindfully practice gratitude, there have been times when I've kept a gratitude journal. And whether it works, if you're a morning person or a night person, you know, whether it works to do this at the beginning of the day or at the end of the day, for me it worked at the end of the day, to religiously every night in that journal write down 3 things that I am grateful for. And I would continue to do that, you know, depending on where I was at in my life and how long the challenges were lasting, you know, for weeks or sometimes months at a time. And to go back and read that and look at that and to try not to put the same thing every day as far as what you're grateful for had a huge impact on just my outlook, my perspective, my mood. It made a huge difference for me. So I do have a book reference where that particular practice came from for me, and it's called The Joy of Appreciative Living. The author's last name is Kelm, K-E-L-M. And that has been an extremely helpful resource for me. So on to the next bullet, involvement, not over-involvement. So we really have to maintain those healthy boundaries and be careful of becoming over-involved. Surround yourself with supportive people that you consider your support group, so to speak. Make sure you spend lots of time with those people. Escape in healthy ways. So, you know, many of those examples were shared throughout today's presentation. Be spontaneous. Be careful of negativity. I always, this is a big one because I think this can tend to happen when people are challenged or stressed and they're kind of colluding and commiserating in those stressful moments and in the negativity of things. And I think we need to all really be careful of that and remember that negative thinking takes a good deal of energy when you think about it that way. So if you stop it, you'll have a great deal of energy that's freed up for growth and enjoyment. And I like to just keep that in mind. And then also be mindful of balance in a number of different ways. So checking your balance in the following areas. So stimulation versus quiet, reflection versus action, work versus leisure, your own self-care versus the self-care of others, self-improvement over patience, future aspirations versus present positive realities, and then involvement versus detachment. I also wanted to share another key way of thinking about self-care from a sensory pathway, and I have another example of something that's been extremely helpful to me and also that I've used in a lot of different with a lot of different populations and a lot of different support groups in the context of their own, you know, creating a toolkit for your own self-care. But there is a sensory pathway to remembering experiences. So I want to focus on this slide a little bit to give you some context for the next suggestion. But at the most primal level in our brains, we experience life through our 5 basic senses, and those are touching, seeing, hearing, tasting, and smelling. So one suggested way to begin a personal self-care plan is to start with these basics. So the senses are often pathways for us to remembering experiences, whether those experiences are pleasant, comforting, stressful, or traumatic. I'm sure we can all likely remember a pleasant time in our lives where we can recall the sights, sounds, smells, tastes, and touches around us. And as much as we can recall those pleasant experiences, there are certain sights, sounds, smells, tastes, or touches that can also trigger stressful or traumatic experiences. So I think one of the most obvious examples of this is with military, active and veteran military who may be suffering from PTSD. And, you know, one of the things that they struggle with is dealing with and managing triggers, so that certain sounds or images or even smells, those types of things can just bring them right back. What I said about choosing items in each of those sensory areas that we talked about in the last slide that soothe you or that bring you comfort, and create a kit so where you can put all of these things. So a bag, a pouch, a box, anything where you can keep all these items so that you can access them whenever you need them. So if we look at the sense of touch, that can be anything tactile. It could be hugs, it could be people, it could be fabric, textures, stones or rocks, special objects. Sight, anything visual, photographs, photographs of special places, colors, artworks, photos of people's faces, sound, anything audible, so music, hymns, chimes, bells, nature sounds, the wind, birds, rustling leaves, really the possibilities are endless in all of these really. Taste, anything you can taste, whether it's a comfort food or a dessert, a spice, a tea, chocolate, that's a big one for me. Smell, anything you can smell. Aromatherapy or essential oils, spices, teas, candles, incense, all of those kinds of things. So I thought I would describe one of my own self-care kits that was created in this vein. In there currently, and over time I've had various different objects in there, and they change all the time. But I have a very small travel candle that has essential oil in it that I love the smell of, and it tends to relax me whenever I smell it. So that's one thing that I have in my own little pouch. I have a special energy stone, usually that I keep in there that I can hold in my hand that soothes and calms me. Often I have a variety of these kinds of stones, and often they have words that are imprinted into them, so I can rub my finger over the words, whether it's breathe, whether it's relax, just as a reminder and to be able to hold something. That would be the touch. The candle would be the smell. And also another example, in my office, I have a little labyrinth bowl. For those of you that are familiar with labyrinths, so there's a labyrinth that is grooved into the inside of the bowl, and you can follow the groove with your finger in a very meditative way. And I often grab that bowl when I need it during my day. So I have peppermint tea or chamomile tea, depending on what I need, whether I need a little uplifting or whether I need to relax. Peppermint gum is another thing I've often kept in there. I use the chimes on my phone, the chime sound on my phone, and I have chimes at home because the chimes tend to ground me, so I use that sound often in my own practice. And then I've also kept my own handmade, so being an art therapist, I go to art a lot for my own self-care, and so I have some homemade affirmation cards in there that have just simple collage images, like pictures that I've cut out of magazines or pictures that are personally special, photographs that are special to me, with words connected, with a single word connected to the image that, you know, brings me comfort or peace. So the next, with that, we're going to move on to the next couple of slides, our video slides. So there are several of them that are one after the other, so there's about 4. If it's possible at the break between each video, I'll just make a few brief comments before we start the next one. So if we can move on to the first one, that would be great.
I also write, so I keep a journal. The nice thing is that I'm just a dumb surgeon who's not very literate, but the nice thing about the iPhone is that there's a portion here in the notes section, and I can go to the notes section, as I have here, and as I do often, I can just push the note, and I am speaking about how I deal with stress and how I journal when I'm too tired to write. It comes up, and then I can edit that later. So it's a strategy, because I think sometimes we almost have to talk to ourselves and see how we've talked to ourselves to get ourselves back on track. And that way we have a way of being our own best friend.
Okay, so you heard a little bit about journaling and the progressive idea of using technology for journaling when we're too tired to write, as well as the importance of self-talk. We're ready for the next video.
I also, I'm a spiritual person. I pray just because sometimes it does seem so senseless, like these things that happen to innocent kids, and you just want to find the answer, like why does this keep happening? Why is it this child is taken away? Why don't the bad people, why don't they catch the stray bullets? Why does it have to be the little 2-year-old who's playing outside? So that's usually what I do. Just go home, veg out, spend some quality time with friends and family, just try to take it easy.
So there you heard a little bit about prayer, spirituality, the difficulty of dealing with non-accidental traumas, and I think in the example that Regina spoke about, really how prayer and her spirituality really helps with those existential why questions that are often inherent in our work and frequently trip us up. We're ready for this one?
And I think specifically on a couple of our patients, we've had the memorial service that we sit around at the table and we talk about the patients. Those, I think, have been particularly helpful for me, and I've heard good response from our my other colleagues too. Because when you do that often, people are sharing good memories from the patients, and you remember those things about them that made them unique. And that's such a great therapeutic experience. And every time I walk by that wreath in the hallway, I smile. And I think of what I shared about those patients, and it just brings a smile to my face. I think that's great. I think we should do that more. I really enjoyed that. So.
So in that last video, our colleague Kristen talked about memorial services, and so I just wanted to say a little bit about, on a larger scale for our pediatric hospital, we do have an annual what we call Celebration of Lives, and it's a collaboration between a number of different departments, but there's a whole committee that works on it every year, and it's really spearheaded by our our pediatric palliative care team. But really we take the time and we schedule a day every spring to honor all of those children who have passed in the year prior and really celebrate their lives. And parents are invited to come if they choose, and there's refreshments, and we honor each child with a photograph text and words that the family may have just chosen to share with us about that child that we read aloud. And then there's a special story and music and candle lighting that we do as part of that memorial service every year. We also have a memory, kind of a memory scrapbook for each year that we then, whether it's siblings or parents or participants, staff members who are at that Celebration of Lives event can come and add to. They can put, using sticky peel-off paper, they can put memories, pictures, words, stories about particular patients or family members that were special to them that we were honoring that day, and add them into that memory book. And those memory books on an annual basis are stored in our Family Resource Center in our pediatric hospital, and anybody can come back to the Family Resource Center and view those at any time. Those families who come back in, and there have been families who come back in and take a look at those and find the pages where they put something special about their loved one. We also have, I know Kristen in the video talked about the wreath that Nancy has outside of her office, and so I'll let Nancy share a little bit about what that wreath is all about and how it's used, and then we'll go on to the last video.
Sure. The wreath is a simple grapevine wreath. It's about 12 inches in diameter, and I have little ribbons, little half-inch ribbons that I cut that are maybe, I don't know, 4 inches long. And whenever there is a death on a unit, I can bring the wreath to the unit, and we have a little mini celebration of life ceremony there with the nursing staff and the physicians and residents and whoever would like to really remember the wreath. And it hangs outside my office, and anytime somebody has grief or loss that they would like to commemorate, they can come in and share that and tie a ribbon. Each one of the ribbons that is tied on the wreath represents a memory, and it's been a very positively received commemoration.
Thank you, Nancy. So in this last video, we're ready to go. It's our final video with some closing words of wisdom from one of the physicians you already saw.
You mean, what advice would I give myself relative to dealing with traumatic events or the work that we do? It's sometimes a tough thing to say, because part of me would say on one shoulder is the person saying, don't take yourself so seriously. All that you've talked about is really kind of crazy, deep, profound stuff. You know, that's way too, just let it go. I think there's a song from, you know, one of the popular children's movies. But the other part of me would say absorb it all like a sponge, but make sure you adequately wring out the excess fluid so that you remain moist, you may remain receptive to absorb other things, but you don't become so saturated that you become unable to be there for others who may become saturated by the emotions and the events that happen in the workplace. So I think that the real part of me, the advice on the shoulder is to, don't take yourself so seriously that you can't be there for others who need to learn from you as you need to learn from them. And I think that we all learned at an early age A, B, C. And so the new way of thinking of that in medicine is ask, be there.
So there's not much more I can say to add to Dr. Barksdale's closing words of wisdom. So that concludes our presentation, and if we do have time to entertain additional questions, we can do that. Thank you all very much.
Thank you. So I see that we have, go ahead. Did you want to do questions or no? Do we have time?
Yes, there's only 2 questions in there, so I would go ahead and answer them, and then we should be good.
Okay. So regarding, the first question is from Susan Halver. Regarding the ABC huddles, oops, I just lost it here. Is there a safety net in place for when really intense feelings come up? For example, anger, grief, or shame. That would be, again, ABC is the earliest point on the continuum. That would be a situation where we would definitely refer that colleague to maybe an employee assistance plan or additional counseling, or try to offer additional opportunities for them to seek care. And then the second question from Marshall Scott, how has this been used in times of job stress, layoff, etc.? Not only is a member of the team lost, but the environment can feel unsafe. Great question. We fortunately have not had that experience at on our campus. I would imagine that it can be used for any type of traumatic situation. You know, anytime you would have an opportunity for people to share and be very open about their feelings. Dina, do you have any thoughts on that? No? No.
No, not necessarily. I haven't, as far as using ABC.
Yeah.
Yeah, I haven't. We have not used it in that way.
Yeah, we developed it specifically for the trauma and the clinical setting, but that's a really great application of it that we could certainly look into for other arenas as well. Thank you for that. And then Marlene has a question for Sherry, that she missed a comment on a mindful approach. Is that in general or a specific strategy or approach? So here's Sherry.
Okay. So I think if I'm, that might have been right around the time when we had the difficulties with sound. So the specific example and approach that I was talking about was really developing a plan from a very basic level with the 5 senses. And that type of approach, as far as finding soothing items to create a kit that relates to each of the 5 senses, comes from a lot of the dialectical behavioral therapy work. So a lot of times they'll use that in psychiatric facilities with a focus on, and that falls in the category of mindfulness with a focus on self-soothing. So that was when I mentioned the mindfulness piece. That's kind of the origin where that comes from, and then I've just adapted it in different ways for support groups, whether it's individually with someone or whether it's in this context of using it for self-care as professionals.
So let's see, one more question here. I will need the recorded version. Yeah, that's a technical question. So if there are questions that you all think of after you hang up or after you rewatch the video or you show it to other people, please feel free to direct them to APC. They can forward them to us, and we are more than happy to engage with anybody about any of this stuff. This is really a passion for us, and hopefully that came across in our presentation. We would welcome the opportunity to talk about this with anybody or explore how we can have additional applications. So thank you all very much.
Thank you all for your attention. This concludes today's presentation. All participants may now disconnect.